And next, I'd like to introduce Wendy Chung. Since 2007, Dr. Wendy Chung has served as the Chief Epidemiologist for the Dallas County Department of Health and Human Services, the largest local health department jurisdiction in Texas, serving a population of 2.4 million. In this capacity, she has directed acute communicable disease, that's hard to say early in the morning, investigations in Dallas County, including outbreaks of cryptosporidius, pandemic influenza, H1N1, Salmonella, West Nile, and Ebola. Dr. Chung received her Bachelor's of Science degree from the Massachusetts Institute of Technology, Master's of Science in Tropical Public Health from the Harvard School of Public Health, and her medical degree from the University of Texas Health Science Center at San Antonio. Dr. Chung currently serves as the chair of the Infectious Disease Committees for the Texas Medical Association and the Dallas County Medical Society. Dr. Chung.
I am Dr. Wendy Chung, and I serve as the Chief Epidemiologist for Dallas County Health and Human Services. I was asked to share with you some perspectives from the local frontline experience, and I'm happy to do so with our response to the Ebola cases diagnosed in Dallas last fall. And I will do so in sharing with you from the lens of my epidemiology role within our health department. So let me first provide some very quick background about public health agencies in our locale. In Texas, less than a quarter of the 264 counties in our state have a local health department. But since over 80% of the state's population lives in these 62 counties and cities, local health departments are the forefront agencies of public health delivery for the majority of our state's residents. Our population of 2.4 million in Dallas County renders our health department the largest local health department jurisdiction in Texas, since the city of Dallas does not have a separate health department. Epidemiology capacity in local health departments is therefore essential for early detection, control, and prevention of major public health problems. Our department's epidemiologists have had a variety of essential roles in numerous investigations and important events in recent years, including some of the following. In 2008, we visited daily shelters in Dallas, housing thousands of evacuees displaced by hurricanes, in order to conduct outbreak surveillance and prevention. Also in 2008, we investigated a large-scale countywide outbreak of 550 confirmed cases of cryptosporidiosis, which were associated with recreational water facilities. This experience marked the first time our health department had ever used what we call an incident command system, or ICS, for an infectious disease response in order to successfully and closely coordinate our epidemiologic findings with associated environmental mitigation efforts in the 25 cities within our county. In 2009, my team and I were memorably dispatched to interview one of the first two patients diagnosed with pandemic H1N1 in the United States, a child who had flown from Dallas to San Diego. Flown from San Diego to Dallas. We conducted contact tracing interviews and obtained specimens for testing of all members in the child's Dallas household while wearing full PPE, or personal protective equipment. An ICS response structure was again used for our health department's response to pandemic influenza. And in 2012, our epidemiology staff investigated a record number of West Nile virus cases, about 398 by the season's end, with 19 deaths, prompting an unprecedented declaration of a public health emergency in our county and implementation of aerial control measures. In September of 2014, we were in the midst of reporting and investigating our state's first recognized cases of enterovirus D68 in hospitalized pediatric patients, when a traveler from Liberia with Ebola infection presented in Dallas. So in our health department, we have a very small staff of 8 epidemiologists. This is less than 1/3 of the epidemiologic workforce staffing levels that are described nationally in state health departments, where there's a median ratio of 1 epidemiologist for 100,000 population. The CDC Public Health Emergency Preparedness Program has been particularly vital for my epidemiology division, since this program supports 7 of our 8 positions. Although epidemiologic surveillance for cases has a critical role in outbreak containment, it most often will not, by itself, limit an outbreak. It is just one among several important components of an effective response, which can also include clinical case management, laboratory services, community outreach, and logistical support. Significantly, aside from epidemiology and laboratory divisions, our workforce in our Public Health Emergency Preparedness Division in our county has decreased by more than 45% since 2007. The challenges of preparing and responding to infectious disease outbreaks have been increasingly formidable in this context of declining preparedness workforce and hence infrastructure. In July through September 2014, as national health advisories about Ebola were issued, our epidemiology group additionally further disseminated these guideline documents, advisories, and Ebola-related information from CDC and professional societies locally. Here, we are indebted to the partnership of external agencies within our community, which are essential in communicating important public health messages locally. This includes our county medical society that transmits our health advisories to more than 90% of practicing physicians in our area, and our hospitals, many of which further distribute health advisories to their own medical staff membership. We also participated in planning meetings with our hospital systems in our area, and we additionally developed accessible tools such as screening questionnaires and decision frameworks for clinical testing in order to further assist our frontline clinicians in evaluating ill patients with travel history from affected countries. Our own experience with Ebola began on Sunday, September the 28th, 2014, when our on-call health department epidemiologist received notification of a patient from Liberia being seen at a local hospital. There had been prompt recognition of his potential risk for Ebola that day, given his travel history and compatible symptoms, and isolation of the patient in the emergency department. Ebola was confirmed in this patient on September the 30th with the arrival that evening of the largest CDC EpiAid team that had ever been deployed to Dallas to provide assistance. By the time of the CDC EpiAid team's arrival, our group's contact tracing activities had sequentially interviewed and identified all of the community contacts of the index case, with the exception of one household, which would be reported to us one day later. And the hospital had prepared their initial list of potential healthcare contacts. We were saddened by the passing of our index patient on October the 8th, and additionally on October the 11th and 15th, with the confirmations of secondary Ebola infections in our two nurses. These transmissions caused us to reevaluate assessments of risk levels of healthcare workers who were wearing PPE, personal protective equipment, when caring for Ebola patients, and without recognized unprotected exposures. Although there is much conjecture, as with other anecdotes of healthcare worker transmissions, there will never be the satisfaction of certainty about the exact mechanisms by which the nurses became infected. The monitoring periods for the last of the 177 contacts identified with the 3 cases was completed on November the 7th. Our 2 nurses recovered, and there were no additional transmissions among community or healthcare contacts. So among the many challenges our health department encountered during the course of this response, I want to highlight just 3, which are directly related to epidemiologic capacity in particular, since they pertain to our topic today of the importance of public health emergency preparedness infrastructure at the local health department level. First, the scale of contact tracing for this event surpassed our local epidemiologic capacity, because the anticipated scale of continued contact tracing and monitoring would be beyond the capacity of our small numbers of epidemiology staff. The CDC EpiAid field team's ready assistance was appreciated and necessary. We had no other resources available to us for provision of this level of on-the-ground assistance and expertise. Our traditional source of some epidemiologic surge capacity in the past has been our Medical Reserve Corps volunteers, and they could not be used for this particular event. Increasing and supporting local epidemiologic staffing beyond the minimum necessary for daily routine investigations is critical to ensure capacity for outbreak responses. Secondly, we lacked important information technology capacity. Among an epidemiologist's banes are the data challenges, which are always more prominently featured during the course of an outbreak. Not only do we not have enough persons within our department for data management, we did not have a data system which could allow multiple user data entry and access, nor be easily configured for new variables, such as ongoing exposures of healthcare workers during an evolving response. Even a very well-resourced health department like New York City's described needing 12 full-time staff members dedicated to data management and monitoring healthcare contacts. Our experience was similar. CDC assistance here again was essential, as their field members comprised our entire initial data team, with CDC even providing a server on site at our center of operations at the hospital for improved data management. Long-term fixes in the form of investments in more robust IT systems locally are not achievable through singular allocations of resources, but instead they require sustained base support. And thirdly, meeting what we call the non-clinical needs of our monitored contacts, particularly for those under what we call movement restrictions, those in voluntary quarantine, for example, directly impacted our epidemiology staff. Our epidemiology staff served as contact tracers who found themselves additionally tasked with spending time in the roles of assisting and relaying, coordinating, and delivering resources to meet needs of contacts, such as the needs for rent assistance, utilities assistance, assistance with procurement of food and household items. Meeting these needs was truly a community effort and also required one full-time CDC leadership-level field staff member to reach out to and coordinate local volunteer and philanthropic resources, as well as personnel outside of our usual public health preparedness division. In this case, members of our county Office of Emergency Management who dedicated much time and care arranging services for contacts. Again, maintaining sufficient preparedness workforce infrastructure within a local health department is important to retain the capacity to not only execute and coordinate necessary mobilization of local resources during response, but also to engage in the depth of planning and the wide range of essential community partners to ready resources, ideally prior to emergency events. So in closing, this was an infectious disease response which underscored the collaborative strengths and intense coordination of federal, state, and our many local partners. The response needs during this event were quite clearly beyond the resources and capacity of our single local health department and agency. We valued highly the necessary support which was provided to us on many fronts by the over 30 CDC field team members who worked tirelessly alongside our teams, CDC EOC assistance from Atlanta, and our state health department preparedness staff. That the keys to genuinely achieving lasting, long-term solutions with some of the needs noted during this response are commitments and investments to strengthen the capacity for frontline preparedness in our local communities. Thank you.